Good morning. My name is Luis Alexandre, and today we are going to start our course on eye genetics. We are starting from the basics, basic concepts, and so let's go. What kind of patients do we usually see in the eye genetics clinic? So those patients are patients that present some type of genetic condition that is affecting somehow the visual system. All right. A few singularities when doing clinical, when we do our clinical history taking on patients with genetic eye diseases. It is very, very important. It is crucial that we make a very comprehensive and complete review of systems. And why do I say syndromic genetic eye diseases are very common? And if we just look at the eyes, we will many times lose other parts of the body that may be affected by that same genetic condition, by the same cause. So it is very, very important. It makes a whole lot of difference if we perform a very good, very comprehensive and complete review of systems. So we always have to keep in mind that. And also, we need to know how to draw our pedigree. It is very important and it is very common in ophthalmology when residents are beginning or even ending their residency program, that they still don't know how to properly draw a correct pedigree. And sometimes we know it, but when you do your history taking, you have to actually draw it and do it the right way so that anybody that sees your chart will be able to understand everything that you made in your pedigree. All right. Another singularity that we see in patients with genetic eye diseases is that we need to examine the whole family. We need to ask the patient to bring his relatives, to bring his parents, if he has or she brothers and sisters, also to bring them at the next consultation. And this is extremely important because many times we have diseases that may have what we call a phenotypic heterogeneity, where the same gene with the same mutation may have different phenotypic presentations, and that may be very helpful because we know that some genes, they behave like that. Some genes, they usually can show us different phenotypes, and other genes they don't show us very different phenotypes. It's sometimes a very unique phenotype. So when we examine the whole family, it gives us the opportunity of doing the right etiological diagnosis in a easier and more efficient way. Also, we have to be prepared to ask for different ancillary tests, and many times tests that we are not usually tests that are not usually on our everyday, on our daily basis. Tests that we are accustomed to ask. Again, another singularity that is very important is that we cannot rush when we are doing our history taking, because genetic eye diseases they can be very complex. Like I said, we can have different parts of the body affected, so we have to give our patient time so that the patient will tell us everything, and then that obviously takes time. So it's not a quick consultation. Many times I can stay 1 hour and a half, sometimes 2 hours, and my record was 4 hours with just one patient, but then I was able to achieve the right diagnosis. So it is very important to give time, all right? And also we have to learn how to ask for a genetic test, and after that we have to learn how to interpret a genetic test. Talking about pedigrees, it is, like I said, we have to know how to do it, and we have to follow a lot of rules. So to draw a pedigree, to write a pedigree according to the rules, there are 2 papers published in '95 and 2008, and those 2 papers they give us a nomenclature explaining all the symbols, everything that we need to know and to understand, so that we can draw and make a complete and understandable pedigree. So let's see the symbols that we have here. So for example, here we have a square. A square is a male. Here we have a circle. A circle is a female. Here we have a diamond. When we draw a diamond, it means that we are not saying if it's a male or a female. It can be anyone. Here we have what we call a situation where we have a heterozygosity without a disease. Here we have when we have the square or a circle with a full color inside, it means that it is an affected individual. Here the arrow with the letter P means that we have a proband. So a proband is someone that has a disease, and that we are seeing that person, we are doing the history taking for that patient in particular. So when we have the square with a question mark up here, it means that that patient doesn't know anything about his parents. For example, he may be adopted and he doesn't know who his parents are. For example, when we have the square with a full circle inside, with a painted circle inside, it means that the patient is a carrier, but the patient doesn't have the condition, the genetic condition. When we have, for example, let me find it here, this condition here, this symbol, it means that the patient has a genetic mutation for a particular condition, where other people in the family have the same mutation and have the disease, but here the patient doesn't have the phenotype yet, but the patient can have the phenotype later in life, or the patient may not have it. Here we have, for example, a patient that has infertility. So when we do this double line here, it means that there is an infertility. On the other hand, when we have just a single line here, it means that the patient chose not to have children. When we have, for example, this here means that we have twins in a monozygotic way. And when we have this here, we have dizygotic twins. When we have this here, this line here means that the patient is deceased. When we have a triangle, it means that here is a male that had was the gestation didn't come to term, and it was a spontaneous abortion. So here we have other symbols. That means that the gestation, the pregnancy didn't come to fruition. It was interrupted. When we have the line across the triangle, it means that it was a provoked abortion, and here it was a spontaneous abortion. And we have to say the gender of the patient, if it was a male or a female, since the triangle doesn't mean if it's a male or a female. When we have this here, means that it is an adopted individual. When we have this these lines crossing a marriage here, it means that the couple got separated. They are not together anymore. When we have the letter E plus, it means that the patient was evaluated for a test or for some kind of test. And when we have, for example, the ECT, it means that it was also a pregnancy that haven't come to fruition, and it was due to an ectopic pregnancy. When we have a number inside a symbol, it can be a diamond, it could be a square, it could be a circle. The number means that how many people we are talking about in the pedigree. So for example here, it just means that I'm talking about 4 individuals, that I'm not saying if it's a male or a female. When I have this symbol here, it just means that the patient was evaluated. I'm not saying what kind of evaluation was done, but just evaluated, and maybe positive for some test. When we have the double line here, uniting 2 people in a marriage, it just means that they are related. They can be first cousins, second cousins, but they are related somehow. And the letter SB just means that it a pregnancy that came to fruition, that came to term, but the baby in this case was a stillbirth. So this is what it means. Let me see if there was something missing here. And the key. So every time that we make a pedigree, it is important to have a place where we can write what kind of evaluation we are talking about, what kind of disease is being displayed in the pedigree, and that's it. All right, so here we have all the pedigree symbols, and we are going to see some pedigree examples. And it is very, very important to also to speak about privacy and confidentiality when we draw a pedigree, because imagine that you are talking to a family member, and then you see everything in the family, and then you start to draw your pedigree, and you show how many brothers, how many sisters, the order in which they were born, their parents, their cousins, their uncles, aunts, and so forth. And that actually reveals a lot of that family history, especially if there is some kind of disease. So we have to respect the privacy and the confidentiality of those of that information. And what we have to do is we have to avoid putting full names in the pedigree. Actually, first names only are even better than initials, because when we write initials, you are just giving tips of who that person is. So if the goal is not to reveal who that person is, it's much better to just write the first names. This is when we talk about pedigrees in charts. And also ages. When we put the ages under the individual in the pedigree, it is important to, instead of putting the date of birth, just to put the age. So then you reveal less about that individual. And when you do a pedigree for a publication, for a journal, to write a paper, then instead of putting first names, we put just numbers. So you will see how we put the numbers just to identify each individual in the pedigree. And of course, again, ages instead of full dates of the date of birth. And for example, so here we have a few rules and tips about how to start drawing your pedigree. So you should start with your patient's generation. So let's say that your patient is in the third generation. So you will start by drawing the patient and his brothers, his sisters. You will ask the patient who was born first, if it was a male, a female, and then who was born next. And then from the left to the right, you will put the brothers and sisters in the order that they were born. And then under the individuals, you will put the numbers like that. Numerals are the type of numbers that we put to define each generation, and Arabic numerals are the kind of numbers that we put to identify each individual. And then, for example, let's say that I'm looking at a pedigree and I went to a pedigree that has, let's say, more than 50 people, and I want to say, to talk about one individual in particular. So what do? I use this kind of map where I can say I'm talking about the individual 3, 4. So who is individual 3, 4? It is the individual in this row and in this column here, and so you can identify the individual in this chess format. Also, when you do a pedigree, what kind of information you want to extract from that pedigree? You want to find the mode of inheritance. You want to try to find the mode of inheritance. Why? Because many genes, they show disease, they originate some type of phenotype only in the recessive manner or only in the dominant manner. So that will help us finding the etiology, the right etiology for a particular case. Also, you want to help other members in the family. Let's say that you draw your pedigree, and let's say that when you draw it, you just identify that 5 more people are in jeopardy of being affected by the same condition, and many times we are talking about still young individuals, and sometimes the disease will only manifest itself later in life, and then you are able to help more people in that family. So the pedigree has a paramount importance, a crucial importance, and we have to be able to make it properly. And for example, Here we have an example, and again we have to look at the screen here, and for example, we see all the definitions, the symbols that we saw in the previous slides. And we have the key that I was talking about here. In the key you have all the symbol information. In this example that was extracted from one of those two papers that we showed previously. We can see that we have the triangle here, meaning that it was a pregnancy that didn't came to term, and it was a patient with Down's syndrome. Here it is another condition. So here different conditions, medical conditions, are painted with different types of different ways. And also we have here different evaluations that are shown in the pedigree here. So evaluation 1, so is a karyotype. Here it was a study for mutations in cystic fibrosis, neurological exam, and for example here we have cousins related. A male that is related to his spouse because his mother is related to her father here. So she doesn't have a condition, but she may have in the future Huntington disease, which is represented here by this line up here. Examined personally, so the symbol here just meaning that the patient was seen by the doctor. And who did the pedigree? So we also have here the person who took the history in this example here. And so we have all the relations between people. We have the numbers, the Roman numbers defining the generations. So this is a pedigree with three generations. So we have the Arabic numbers showing each individual in each row. And so this is an example of a pedigree that has the key, has who wrote the pedigree, and with the proper nomenclature, everything done accordingly. How we have to do it. And so we saw the pedigree, and again, and all right, so what subspecialty should I definitely dominate in order to see these conditions, these patients with genetic eye diseases? So it is very important that we know that we have a very good understanding of the retinal anatomy, of the retinal physiology, of the retinal diseases. It is extremely important that we are familiarized with retinal dystrophies, which are quite common in the eye genetics clinics. We also have to dominate to understand very well the anterior segment of our eyes. So we have to know the corneal anatomy, we have to know the corneal physiology, the corneal layers, we have to understand cataracts, not a lot surgically speaking, but the shape of the lens, its position, the zinzonial, how it is, how it stays in the center of the pupil. So most of the anatomy, to understand different types of cataracts, because different diseases, different genetic diseases may have different ways in which the lens can be opaque, and we have to understand glaucoma as well, because there are many genetic conditions affecting the anterior segment where we can have particular and different types of glaucoma. And we also have to know a lot of neuro-ophthalmology, because we also have many genetic eye diseases affecting the optic nerve, the optic chiasm, and also retinal and neuro-ophthalmological conditions combined. We can also see alterations in the optic disc and also in the retina. So we have to have a full understanding of those 5 subspecialties, so that we can perform well, and so that we can see and understand all the conditions that will appear to us in the eye genetics clinic. Common questions patients do in the eye genetics clinic. So in the eye genetics clinic, many times, actually almost every day, some patient will ask us a few questions. For example, we are first-degree cousins. What are the chances of us having another child with the same recessive disease? Well, I assume that many people would answer, oh, the chance is 25%. And the answer is no, all right? The answer is no, and many times the patient asks the question and also answers, saying, so the chance of us having another child with the same disease, I was reading about recessive diseases, we are cousins, so the chance is 25%, right? No, that's wrong. And the short answer is, to answer that question, it is impossible. And the comprehensive answer to that would be, why not 25%? Because there are concepts like penetration, expression, epigenetics, and de novo mutations that will change that number completely. So it may be 30%, it may be 28.5%, it may be 12%, it may be 40%. It all depends on the penetration, it all depends on the expression and the epigenetic factors, and also de novo mutations. So there is no simple answer to that. Another question, so the patient many times comes and say, my vision is very low, my last ophthalmologist told me I had, for example, 20, 30, 40% of vision due to my genetic disease. Is that... So the patient, it's very common for the patient to ask, so my vision is very low. I heard my last ophthalmologist saying that I had just 20% of vision or 30% of vision. Is that it? And the answer is probably not, because most likely he was just guessing, just trying to give you an answer because he wanted a number. But actually, sight is a very complex sense, and for that, the number is not it's not simple to find a right number. So since sight is a very complex sense, it is formed by different parameters. For example, visual acuity, contrast, discrimination, chromatopsia, stereopsis, ocular motility, visual field, dark vision or night vision, dynamic visual acuity, and also cerebral vision, or the capacity to interpret images that are put in front of you. So all those parameters are the ones that will together form the sense of sight. All right, so for each parameter, if you wanted to find a number, you would have to find the right percentage and then attribute a certain weighted average according to each patient. And why would you do that? That is pointless, because you can have, for example, two patients with the same percentage but different parameters being affected, and then they would be treated in different ways, because what is important is to understand what is happening to each parameter and why there is a low visual acuity, or why there is a low stereopsis, or why the ocular motility is affected, and this is important. So just to find this magical number, this magical percentage, is actually pointless. And this is very, very, very extremely common that the patient asks us that. Another common question that we see is the patient saying, what are the chances of losing my vision completely? What are the chances that I can go blind, completely blind? The short answer is almost 0%. And why? The comprehensive answer for that is we just saw that sight is a complex sense. Therefore, it would be virtually impossible, statistically speaking, that someone would lose entirely all their visual capacities, all the parameters affected, completely affected. So that's why it is statistically almost impossible. So always we can make our patient relieved and comfortable that there is always going to be some type of vision left, even in the most devastating types of eye diseases. There is always vision left, almost always. Common questions patients do in the eye genetics clinic again: can I marry my cousin? Well, the short answer is no, you can't. But the comprehensive answer is, medically speaking, you could, if you decide not to have children of your own. Otherwise, you are running into a lot of risks of having many different recessive diseases. And why running that risk with so many people in the world that are not related to you, right? So, consanguinity. Well, consanguinity is surprisingly still a huge problem in the world. We have about 1 billion people in a consanguinity situation still. That is a lot of people, and so that just for us to see that situation globally a little bit, we have the world map here, and we see that the situation is bad in the north of Africa, in the Middle East, and also in the west part of Asia as well. So we can see India, we can see all the Middle East, almost all the Middle East, almost every country in the north of Africa. So those countries, in those countries, it is very common for people to marry and to have children in the family. All right. In the United States, the situation is kind of interesting, because we have a lot of differences between the states. So we can go from a criminal offense where you become a criminal if you marry a cousin, and to places where it is legal to marry your first cousin. So it is very, very interesting, this heterogeneity that we see inside the US. In Brazil, it is written in Portuguese, but what it says is that there was a study here in Brazil where we can see the reference in the end of what is written here, and we can see that if you marry your cousin, the chances of you having disease, some type of deficiency, doubles if you have children with someone related to you, all right? And we also see some states where it is more common. It is more common in the northeast of Brazil, all right? Another question that we usually see patients asking us in the clinic, not another question, but here is more a definition. So define rare disease. So what is a rare disease? We are dealing with rare diseases in the clinic, in the iGenetics clinic on a daily basis, so we need to know that number. And that number varies again from country to country. Not a lot, but we can see that in the US, there was the Orphan Drug Act in 1983, where it was defined that if less than 200,000 of the US population is affected by some type of condition, that means that it is a rare condition. So if we understand that in 1983 the population was around 233 million people, and we do a simple division here, we can see that number would be equivalent to say that a rare disease would be those diseases affecting less than 85, 86 people in a population of 100,000. In Europe, in the European Union, it would be 50 if you have less than 50 people affected in a population of 100,000, that means rare. And in Brazil, the number is 65 or 65-ish, so less than 65 in a population of 100,000, it means that is a rare disease. And here we have just a few simple definitions, but it's not because of the simple definition that I wanted to show this slide. The reason that I'm showing this is just to say, so we all know that those lower capital letters AA mean a recessive phenotype. The uppercase A with a lowercase a would mean many times a normal phenotype, and this is the reason that I want to show you the word normal. So I'm very cautious, and I think we all have to be very cautious with the words that we choose when we speak to our patients. So when we are talking about the disease that the patient has, if I'm saying, so in your case, so we have the normal patient here, so your brothers, I went to see your patients, your brothers that are normal, and then the patients start to feel abnormal, and that is not good when you are talking to your patient. So instead of saying, oh, that is the normal phenotype, it is much better to say that is the common phenotype. So prefer to use the word common instead of using normal, because that makes a difference when you are talking to the patient, especially in genetic eye conditions, where many times the condition is by itself something that is not always easy to cope with, so this is important. Again, so helpful websites. This is very, very important to us, because when we see a genetic condition, many times we are not familiarized with that disease because that's rare. So every week I see a new disease. Every month I see an extremely rare disease, and many times I have never seen that disease, and I always need to be studying and updating and looking to find out what it can be. right? So there are many websites, many databases that will help us with that. And for example, clinicaltrials.gov is a website where we can find studies related to new treatment. And that is very interesting, because our patients, they want perspectives of therapeutic perspectives in the future. They want to know, is someone doing any type of research for my condition? So it is very useful to find it out and to answer the patient. Gene cards. So this is a website that provides very comprehensive as well, and in this database we can find many information regarding the gene structure, the chromosome, the loci, the locus. Hopefully we are not hearing the fire alarm. It's just training. I think not. Perfect. And now we also have this EGI, iGenetics Institute. This is where we see the patients, and we have actually a glossary where we have more than 400 terms that are very useful to check and to find out different definitions in basic genetics and also in eye genetics and in a lot of genetic eye diseases. So that is very useful for consultation as well. And we have the NCBI website, where we have a lot of databases about proteins, about genes, about RNA, about domains and structures. So many databases that will help us a lot as well. And we also have the online Mendelian Inheritance in Man website, which is 50 years now, and also a very comprehensive website where we can see clinical information about the disease, signs, symptoms, important papers that were published, not always like the newest papers, but like very important patients to certain conditions. So this is also a very useful database that we have to keep in mind to provide the best for our patients. So now it would be a good time for us to open our browsers and check a little bit those websites, and then I can show you what to look for, where to find proteins, structures, genes, sequences, phylogenetic information, and all those clinical information as well. All right, and in the next lecture, we will go deeper in genetic testing, in the traditional Sanger sequencing, in the whole exome sequencing, which is more and more popular every day, but it's very there are many details in the whole exome sequencing, many little things that we have to pay attention, not to say that the patient has that diagnosis or not, many false positives, many false negatives. So it's very something that we have to go and look carefully into in the next lecture. And this is how we can communicate, and see you next time. Thank you.